Good evening, everyone. So this week we'll be starting a lecture on ENL, type 2 Lepra reaction. Last week we discussed type 1 Lepra reaction or reversal reaction, and this week we'll be having a good masterclass on ENL. Now, understanding ENL is actually quite easy. Diagnosing is also not that difficult, but we need to learn some certain aspects about ENL. What is the pathomechanism? And what is the epidemiology, what are the risk factors, what are the clinical features, what all different types of presentations that we can see in ENL. So we need to have some sort of understanding about how to look for different clinical features in type 2 lepra reaction. Okay, and that is what we're going to do today. So I will try to make this lecture very short one, and without much further ado, we should start our discussion on Erythema Nodosum Leprosum or type 2 lepra reaction. Let's move forward. So let's brush up what do we understand by ENL. We know that it's an immune complex mediated syndrome. Now remember that there are multiple theories about what is the pathomechanism of ENL, and the most prevalent one or the most common one or the most researched one is that it's because of an immune complex deposition mediated inflammation. And what are those immune complexes? These are antigen and antibody complexes, antibodies made by the host, antigens from the M. leprae bacilli. Okay, so this is an immune complex syndrome, and there's also an increased activation of complement system. We have discussed complement system before. The video is there on the channel. You can just go through it. Now, there is increased inflammation because of activation of complement system. So a good definition would be complement mediated antigen antibody immune complex deposition mediated inflammation. I know there are so many words, but this tells us a bit about what actually happens in EM. So, as far as hypersensitivity reaction is concerned, it's a type 3 hypersensitivity reaction, also known as Arthur's phenomena. But remember, it's a type 3 hypersensitivity reaction. The type 1 lepra reaction was type 4 hypersensitivity reaction or delayed type hypersensitivity reaction. So, to cause less confusion, I'll use the term immune complex reaction. Okay. So what actually happens is we have the IgG antibodies from the host, IgM and C3 complement all from the host plus antigens from the M. leprae, and these two come together to form immune complexes. Now these immune complexes will be in the circulation. They will get deposited into different organs. If it goes in skin, it causes ENL. It can go in liver. It can go in joints. It can go in kidneys. And wherever they go, inflammation follows. And because of that inflammation, we see the clinical manifestation of ENL. Okay. The lesions that happen in skin, the cutaneous lesions, they resemble erythema nodosum. The lesions that we see in erythema nodosum, they have the nearly similar morphology. Hence the term ENL, Erythema Nodosum Leprosum. That means the lesions occurring in leprosy that resemble Erythema nodosum. So ENL. Now, ENL is mostly seen in patients who have high bacillary index. That means high bacillary load towards the multibacillary portion of the spectrum, where the amount of bacilli inside the body is quite large. Okay. ENL plus other symptoms like fever, myalgia, arthralgia, any kind of liver damage, kidney damage, total constitutes type 2 reaction. So what I want to say is you have the entire spectrum, entire cohort of symptoms of type 2 reaction, and a subset of that is ENL. So when we say ENL, we mean that the cutaneous plaques are known as ENL. If you add other symptoms like constitutional symptoms like fever, joint pain and all, then in totality that becomes type 2 reaction. So this whole is type 2 reaction. But in normal parlance in our clinical practice, we may use these two terms interchangeably. We can say it's a patient of LL Hansen in ENL. So that's what we want to say. We want to say the patient is in type 2 reaction. Okay. But just keep that distinction in mind that ENL is cutaneous manifestations. Along with all the symptoms, you call it as type 2 lepra reaction. Okay, let's move forward. So, if you learn about the epidemiology, or if you try to search the internet regarding epidemiology of ENL, you will have different sorts of data. For example, as per one study, and I've quoted that study, the article below, about 1.2% of all leprosy patients will have ENL, are more prone to having ENL. A majority of that, which is 4.5% roughly, are the MB patients. That means 4.5% of multibacillary patients will have ENL. About 50% of lepromatous leprosy pole, that is the lepromatous side of the spectrum, will have ENL, but that's quite a high percentage. In fact, in some of the articles I've read about 15 to 20%. So remember, in lepromatous pole, where the bacillary load is very high, the chances of developing ENL is also high. Okay. And in the case of BL Hansen's, it could be 10%. However, in some of the articles, I have seen 4% also mentioned. So you will get different data depending on what sort of population you are analyzing, but you can have some sort of idea that about 2 to 3% of all leprosy patients will have ENL. About 30 to 40% of LL Hansen's patients will have ENL, and about 10-15% of BL Hansen patients will have ENL. So just have some kind of understanding regarding the data. Otherwise, data varies a lot between different articles. Okay, let's move forward. So, like we discussed last week regarding the risk factors for type 1 lepra reaction, we'll discuss risk factors for type 2 lepra reaction. Now, the most important risk factor is LL Hansen. We know that ENL is much more common towards the lepromatous pole of the spectrum. And why is that? Because of high bacillary load. More the number of bacilli, more the chances of developing ENL. Okay. The relative risk of developing ENL if you have LL Hansen is 3.6 times. That means a person with LL Hansen is 3.6 times more prone to developing ENL as compared to another patient who doesn't have LL Hansen. The second risk factor is MDT. Now, we know that most of the reactions, type 1 or type 2, do occur when the treatment is started. In type 1, it happens because of destruction of bacilli. In type 2, it happens because of immune recognition and different cytokine release. We'll discuss in detail in a few slides afterwards. And the sheer act of initiating MDT can precipitate ENL. So all the drugs, dapsone, rifampicin, all the drugs have been implicated except clofazimine. Clofazimine has found to stabilize and decrease ENL, and that is why in type 2 lepra reaction, clofazimine is one of those drugs that can be used to control it. Okay. Now BI more than 4 plus. So more than 4 plus bacteriological index is an independent risk factor to develop ENL. In fact, BI of more than 6 has a relative risk of 8.6%. That means if a patient has more than 6 BI, chance of developing ENL is 8.6 times the patient who has less than 6. Okay, so if your BI is 6 or more, you have 8.6 times developing chances of developing ENL. Now, age 40 years that has been implicated. Intercurrent infections. Now, streptococcal, viral, intestinal parasites, filariasis, malaria, any sorts of infections that can pose any kind of stress on the body can act as a trigger for developing ENL. So, any kind of short-lived illnesses can trigger. In fact, the normal developing viral fever can easily trigger ENL. Any kind of stress. The stress can be physical, mental, psychological, okay, all these kind of stresses, emotional stress, all of these kind of stresses can actually act as trigger for developing ENL in a patient who is LL Hansen's. More than 5 nerves enlarged is an independent risk factor of developing neuritis with ENL. Neuritis with ENL. So more the number of nerves that are enlarged, more is the chance of developing ENL. Clear? Let's move forward. Now, coming to the pathomechanism. So quickly we'll go through pathomechanism. Simply speaking, immune antibodies made by the host body against antigen from M. leprae form complexes deposited in the organs, and then the immune system acts against those deposited complexes, leading to inflammation. That is the simplest way of describing ENL. But we will not study simply, we'll complicate it further. Okay? Now, we know that the major action of immunity is through the T cells. Okay, we have discussed skin immunity in detail. There are lectures on the channel. You can go and search and go through it. The major cell population that acts for immunity are the T cells. In this T cells, you will have majority of CD4 positive cells. Mostly, whenever the immunity acts, you have majority of CD8 plus cells. But in ENL, the CD4 positive cell population starts to increase. And that is known as reversal of CD4 to CD8 positive ratio. So normally CD8 is more than CD4, so ratio would be less. But during ENL, gradually the shift happens and CD4 positive cells increase and they replace CD8 suppressor cells. Okay. So initially there is minimal increase in T cells, which are CD4 positive cells, but with increasing duration, it surpasses the population of CD8 positive cells. There is increased mRNA for IL-4, IL-5, 13 and 10, which points towards Th2 type of reaction. Remember, type 1 lepra reaction. Type 1 lepra reaction was Th1 reaction. And type 2 lepra reaction is Th2 type reaction. Interleukin 4, 5, 13, these are all Th2 cytokines. Okay. So what happens is you have monocytes in lepromatous leprosy granuloma. We know in lepromatous leprosy, the granulomas are somewhat loosely formed and they are filled with foamy histiocytes. Why foamy? Because macrophages or monocytes or histiocytes have engulfed M. leprae, but they are unable to destroy it. So they are filled with M. leprae, but they don't know what to do about it. So these kind of foamy histiocytes are there. When the host goes towards ENL, these histocytes, these macrophages, these monocytes, they get activated. And when they get activated, they will further activate macrophages. Now, these macrophages, they will eat all the foamy macrophages that have M. leprae inside them. So normally you have a macrophage and they are filled with M. leprae and they are unable to destroy the M. leprae and no destruction happens of M. leprae. But during ENL, you have other macrophages which get activated, and then after activation, they will go and attack the macrophage which is filled with M. leprae. Clear? When these M. leprae filled macrophages are attacked, they will release antigens which are the leprae antigens because now the leprae are getting destroyed. And these antigens are presented by other macrophages to the cell-mediated immunity. So what happens is, if I want to rephrase it, you have a macrophage which is filled with M. leprae but is unable to kill it, unable to destroy it. When ENL happens, active macrophages, these are new population, active macrophages will come and attack the lipid-laden or the foamy macrophages. This attack kills the destroys macrophages, destroys the M. leprae. Destruction of M. leprae releases antigens. These antigens are taken up by different population of antigen presenting cells, and then they utilize these antigens to present it to cell mediated immunity, mostly NK cells and T cells. Okay. But remember, we are talking about the lepromatous pole. So in lepromatous pole, the immune system, even if it recognizes M. leprae, is unable to destroy it. So what happens is antigens will remain. The body will not be able to clear the area of antigens, and these antigens will then form complexes with antibodies. So body will form antibodies, body will increase CMI, body will also increase the immune reaction, but unable to destroy bacilli because of the sheer high bacillary load and immune non-reactivity. When the antigens are left, they will form a complex with antibodies, and these complexes are known as immune complexes. And then they will deposit themselves into various organs. And after deposition, the immune system starts to attack those organs, leading to features of type 2 lepra reaction. Clear? If there's any doubt in pathomechanism, mention that in the comment section with the timestamp and we'll have a discussion there. Let's move forward. In the previous few slides, we have discussed the pathomechanism of ENL. So what actually happens is all the inflammatory cells, whether they are at the level of skin or they are circulating in the blood, they get activated whenever there is slight leakage or you could say slight release of antigens from M. leprae. So what happens is when these immune cells, they get activated because of M. leprae antigens, they are going to attack the places where M. leprae is there, the same thing which happens in T1 reaction. But this time the M. leprae is not in the tissues. It's inside the macrophages, safely staying there because of immunal energy. Okay, immunal energy. What do we mean by immunal energy? Immunal energy means that immunity is not able to elicit a good response against M. leprae antigen. Clear? So what happens is that when that response is not there, but newer and newer immune cells are continuously recognizing M. leprae antigen, they're going to destroy those antigens along with destruction of those macrophages that have M. leprae bacilli. Now, this will lead to more release of M. leprae antigens because more and more destruction is happening. Now, these antigens, they form complexes with the antibodies in the system. And when this happens, these immune complexes consisting of M. leprae antigens and IgM IgG antibodies against M. leprae antigens, these together will form immune complexes. And these immune complexes will deposit in various tissues and cause inflammation. That is what is known as ENL. Clear? So in type 1 reaction, the immunological process was happening where we had M. leprae and it was not disseminated. It was restricted to the lesions which were there of leprosy before. But in ENL, these immune complexes go inside the circulation and they can reach every part of the body, nearly every part of the body, and there the inflammation happens. And then that is why in ENL you have a widespread immune reaction. Clear? Now we know that in ENL is a Th2 response. That means the major cytokine that works in ENL is TNF alpha, and which is a pro-inflammatory cytokine. There will be a lot of inflammation. That is why the lesions of ENL are red, tender, warm, there's fever, there's constitutional symptoms. In fact, TNF alpha is also a pyrogen. That means it induces the development of fever. Clear? There's also IL-4 response, which is another Th2 cytokine apart from TNF alpha. What IL-4 does is it activates plasma cells to release antibodies, and furthermore antibodies along with antigen will again form immune complexes. IL-4 also activates B cells. B cells also release antibodies. The same thing is going to happen. You will have further immune complexes. IL-4 is also stimulated by mast cells, and mast cells lead to inflammation, vasodilation, increased vascular permeability, swelling. So all these kind of features are mediated by IL-4 and TNF alpha together. We know that complement system is also activated in ENL. That leads to increase in the levels of C3D. Okay, but the latest theory says that C3D could be just a bystander molecule, increase because there is inflammation happening, not as a pathomechanism of ENL. Clear? Let's move forward. Hi. Hope you're enjoying this video. I know it's a long video, so I thought I'll give a certain break after listening to such a long videos that I make. If you think that these videos are helpful in your residency, do consider becoming a member. You can opt for Sapphire membership or Ruby membership. I would prefer it to be a Sapphire membership, of course. Um, you get access to longer videos, bonus contents, extra information to make things more interesting, and to cover each and every aspect of the topic that we are discussing. Okay, so I think that's enough of a break. I should continue with the video, and you should listen to the other person at the bottom right corner tell you different topics of dermatology, immunology, and nephrology. That being further said, let's continue with the video. Coming to histopathology, what do we see in biopsy if we take it from an ENL lesion? You have the background LL or BL histopathology. Remember, ENL occurs more in the lepromatous fold. So because of that, what actually happens is you have a background of Hansen, and over that you have inflammation. Clear? There is dense infiltration of superficial or deep and or subcutaneous tissue by neutrophils. Remember, neutrophils are the histological hallmark of ENL. So there's dense infiltration in the upper lower dermis along with subcutis, and the infiltrate is composed largely of neutrophils. The infiltration extends inside the loose granulomas, so much so the infiltration can be so high so that it can cause microabscess. So collection of neutrophils are known as microabscess. Then you have destruction of the vessel wall known as vasculitis, and this vasculitis is also a very important feature of biopsy of ENL. So any kind of, you could say, upper, mid and lower dermal infiltrate composed mainly of neutrophils along with vasculitis with a background of Hansen's involving the subcutis also points towards type 2 lepra reaction. Collagen and elastic fibers are also damaged. The bacilli are fragmented and granular because destruction is happening. And in the lepromatous pole, you have so many bacilli that their destruction leads to so many granular and fragmented bacilli that is easily visible on AFB stains. If it's necrotizing ENL, then you see necrosis and ulceration of the epidermis along with few part of the dermis depending on the extent of involvement. Let's move forward. Now look at this biopsy. I've taken these pictures from this article. I've mentioned that in the description. Just read this article. Very good article on histopathology. Okay. What you see is a well-demarcated neutrophilic rich infiltrate involving the upper dermis, mid dermis, lower dermis, and in fact extending to the subcutis. Here you can see the inflammation. Clear? In fact, you can see a little bit of vessel wall damage here, here, and here. And in this section shows a very good subcutaneous infiltrate composed of neutrophils. Look at this lobule. This lobule has infiltrate in between the cells. Even if you cannot make out the nature of infiltrate at this magnification, you can still see the infiltrate. So the infiltrate is involving the lobules. And if you go on higher magnification, you'll be able to recognize neutrophils. So in ENL, there is lobular paniculitis like picture with neutrophils along with a slight septal thickening that is not appreciable, but you can go on higher magnification and see it. Let's move forward. So look at this kind of highly neutrophilic rich infiltrate. You can see it's filled with neutrophils. You may have occasional, like you can see here, this is like I think it's an eosinophil. So majorly, any cell you pick, high chances that you will reach a neutrophil. So it is a neutrophilic rich infiltrate. Let's move forward. So let's go to clinical features, and now we won't spend much time. We'll just go through clinical features fast. About 21% or about 1/5 can present with ENL at the time of presentation in clinic. About 1/6 of them will develop within 6 months. Next 1/6 will develop in the second half of taking MDT, while about nearly half or 44.5% will develop after 1 year starting MDT. So ENL can happen at any given point of time. It can happen in history at the time of presentation, within 1 year, after completion of MDT also. So keep that in mind. But majority of them, they start after MDT, after 1 year of MDT, or if MDT is still being given. The lesions of ENL are described as painful, tender, evanescent. Evanescent means short-lived. Painful, tender, evanescent, maculopapular, papillary, nodular, or plaques. So all different kind of morphologies can be present. Afterwards, the patient complains of constitutional symptoms like fever, malaise, joint pain, myalgia, arthralgia. In fact, in 1/3 of cases, joints can be involved. Joint involvement can be before development of ENL or coexistent with constitutional symptoms, and they can mimic connective tissue disorders. So all the disorders like SLE, Angstpon, even rheumatic arthritis, you can confuse the joint pain of ENL with these kind of CTDs. Remember, joint pain is there in 1/3 of patients. If you see a patient of ENL, ask them about joint pain. The joints most commonly involved are the knee, then metacarpophalangeal, then interphalangeal, and then wrist and ankle joints. If there's chronic or recurrent joint inflammation, it can lead to permanent disability and deformity. But mostly all symptoms occur nearby each other. So in ENL, there's a sudden appearance of crops. Crops means multiple together, like a crop, like a shower, okay? Multiple together. Sudden appearance of crops of evanescent, that means lasting few days. Erythematous, painful and tender papule nodules and plaques which are variable in size. They are dome-shaped and ill-defined. That means they are raised above the skin lesion. Symmetrical, you will see a more or less symmetrical distribution. While in type 1 reaction, that could be asymmetrical because the lesions of leprosy in tuberculate pole is asymmetrical. Yeah, okay. Most commonly it is seen in outer aspect of thighs, legs, face, mainly face and areas which have a lot of fat content like thighs, trunk, stomach, back, okay. Areas like hairy scalp, axilla, groin, perineum, warmer areas of the body, these are areas which are devoid of ENL or the chances of ENL is very rare. Why? The IEL doesn't mention. Okay, but just remember these areas: hairy scalp, axilla, groin, perineum, and warmer areas of the body. Mainly maybe because M. leprae is not affecting these areas because of temperature. We know that M. leprae wants to multiply at colder areas of the body. Since these are warmer, they don't multiply that much, and the level of inflammation is not much, leading so that ENL doesn't develop in these areas. That could be one of the reasons. Let's move forward. Other features that are included with ENL are myositis, arthritis, synovitis, joint pain, rhinitis, epistaxis. You need to ask history of epistaxis, laryngitis, iridocyclitis, glaucoma, painful dactylitis, which is known as reaction hand. Lymphadenopathy is tender and swollen, especially the inguinal group and the femoral group of lymph nodes. If the lymph nodes get ulcerated, it leads to a discharging sinus formation, and in that discharge, you can easily stain for M. leprae. It is teeming, it is filled with M. leprae. Other organs like testicular involvement leads to acute epididymoorchitis, and when it is recurrent or chronic, it can even lead to testicular atrophy and gynecomastia. As a part of low testosterone, because the repeat inflammation testis leads to testicular atrophy. Kidney involvement is by nephritis, proteinuria, renal failure. Liver is involved in the form of hepatosplenomegaly. Anemia can happen either because of chronic inflammation, as anemia of chronic disease, or because of malnutrition, or because the increased inflammation takes a toll on liver, which is not able to secrete enzymes and proteins required for proper hematopoiesis. Clear? The treatment is to give steroids, and if it is severe, blood transfusion has to be considered. Repeated inflammation leads to amyloidosis. So inflammation, we know inflammation can lead to amyloidosis if it is long-standing. Amyloidosis if it is long-standing. Okay, and this amyloid protein can be deposited in various organs, and the most susceptible organ are the kidneys. So get a urine routine microscopy to look for RBC WBC cast in a patient who is suffering from ENL, especially if the ENL is severe, chronic, or both. Systemic features include intermittent fever, malaise, prostration, headache, muscle and joint pain, and these symptoms can precede ENL. They can be seen before the ENL. By ENL, we mean the skin lesions. Before ENL even develop, they can be with ENL and they can be after ENL also. And these are just because of the release of various cytokines like TNF alpha, interleukin 4, 5, 15, and all sorts of inflammatory cytokines. Coming to nerves, the nerve involvement is less common as compared to type 1 reaction. Neuritis and nerve involvement is more common in type 1 reaction. Many features like nerve compression, vasonervosum compression. Vasonervosum are blood vessels that supply nerves. Okay, so vasonervosum compression, this can lead to acute symptoms because infarction of the nerve happens, or interruption in blood supply to nerves happen, and because of that it leads to acute symptoms. There can be points of entrapment. Points of entrapment are those areas where nerves pass through a very narrow space. So if there's any swelling around the nerve or around this narrow space, it can lead to compression of nerves, leading to neuritis or neural involvement. For example, ulnar groove for ulnar nerve, Guyon's canal for median nerve, fibro-osseous canal for common peroneal nerve. Okay, tarsal tunnel, all of these areas are where nerves pass through a very small place and they are susceptible to compression. If there's direct damage to nerves, remember NCAM positive mark of over-Schwann cells getting attacked by CD8 positive cells. They can lead to nerve trunk inflammation, which can further lead to neuritis. So neuritis is a multifactorial issue, and all these factors come together to damage the nerves. Let's move forward. To diagnose ENL, since in last week also we discussed NAF criteria. NAF criteria to diagnose type 1 lepra reaction. The same criteria or the similar authors have given another criteria for to diagnose type 2 lepra reaction. In this criteria, you should have one major or three minor. So the major criteria is acute erythematous tender papules nodules plaques with or without ulceration. So lesions of ENL, ENL. Minor criteria is mild fever or a feeling of unwell, tender enlarged nerves, increased loss of sensation or muscle power, arthritis, lymphadenitis, epididymoorchitis, iridocyclitis or episcleritis, edema of the extremities or face, and positive Riley or Ellis test. So when three minor are present, you can diagnose it as ENL. Differentials of type 2 Lepra reaction include type 1 Lepra reaction, but remember, in one single patient, you can have type 1 and type 2 reaction, especially if they belong to the BL pole, okay, or BB pole. So if they are there, also remember, the type of reaction depends on what kind of cytokines are being released, and that is dependent on multiple factors. So keep that in mind that you may be able to see both the reaction in a similar patient, and type 1 reaction remains a differential for type 2 lepra reaction also. Rheumatic fever, I told you they can be confused with CTDs, rheumatoid arthritis, collagen disorders like SLE, drug reactions. Remember, I told you I had a patient who was admitted for drug reaction, turned out to be ENL, and paniculitis, because that is what ENL is. It's erythema nodosum like picture. Okay, let's move forward. After such a lengthy discussion on ENL, we will not spend much time on treatment, because if you want to learn the treatment of ENL, you need to see patients of ENL. That's how you will learn. Okay, WHO has made a protocol of how to what to give, how to give, how to taper. But best way to treat ENL is to see patients with ENL and treat them, because everybody has different protocols. Remember, you have to manage it effectively and quickly. So whatever works for the patient is okay for the patient. You go for it. The major motive is that you have to control inflammation, pain, and tenderness. You have to control constitutional symptoms like fever, malaise, and joint pains and other involvement. Prevent recurrence of ENL. Remember, recurring ENL can cause a lot of deformities and disabilities. Prevent disabilities. Continue MDT. MDT should not be stopped. It is you have to continue MDT, and a lot of hand holding and counseling. Remember, ENL is very detrimental to the mental peace. Okay, you are suffering from Hansen's. You have to take treatment also regularly. You have to lose wages when you develop recurrent reactions. You are fed up of the disease. So hand holding becomes a very important aspect regarding the treatment of ENL. Clear? Since we have discussed ENL, we know that it's an intense inflammatory reaction. So we need to use anti-inflammatory modalities. We have to use NSAIDs to take care of inflammation and pain. Corticosteroids remain the first line treatment of type 1 lepra reaction. In fact, in type 1 lepra reaction, you can get away with using NSAIDs, but in type 2, if you can, use steroids to control the current episode and then maintain on drugs like clofazimine or thalidomide. Thalidomide is an effective treatment, but a lot of side effects like DVT and neuronal issues. So you need to keep that in mind. We have a separate video discussing thalidomide. You can find it in the Leprology playlist on the channel. Clofazimine, anti-inflammatory, anti-neutrophilic molecule, about 300 milligram a day is enough, but you can taper the doses according to severity. But it's a very slow-acting drug. Takes about 4 to 6 weeks to properly act. It has its own side effects. We have discussed clofazimine in a separate video. You can find it again on the Leprology playlist. Cyclosporin, methotrexate, azathioprine to control inflammation. We know ENL is a TNF alpha mediated disorder. So TNF alpha inhibitors like infliximab, etanercept, adalimumab can be used. Mostly etanercept and infliximab have been used, but they have their own effects and side effects. We have a separate video again on infliximab and etanercept and adalimumab. You can go and look at the video under the heading of biologicals. Apremilast has also been tried in a very few small cohort of patients, found it to be more or less effective to control inflammation. So with that, we'll finish our masterclass on ENL. We have discussed ENL in detail. Nearly every aspect of ENL has been discussed in gross detail. And if you have any doubts, just mention the timestamp, mention your doubts in the comment section, and I'll answer them. These are all the different lectures that are available on the channel. Go through them. They will help you in developing a good understanding of leprosy. Remember, we are leprologists. We need to know about leprosy. And leprosy as a disease is very interesting to read about. Okay. These are the reading recommendations. If you want to learn more about pathology, read this article for pathology. And you can read this to understand what are the newer insights in ENL. These are the reading recommendations. But if you go through this video lecture, more or less you know each and everything about ENL that are asked in the exams, or also to develop a holistic understanding of type 2 lepra reaction. Again, reminding you about the Ruby membership. If possible, do become a Ruby member. But remember, in coming few months, I plan to discontinue Ruby membership. So it's better that we shift to Sapphire member. You think that these videos you have found it to be helpful and they are worth the buck. They give a good amount of bang for the buck. Do consider becoming a Sapphire member. I'll try to add more and more perks to the Sapphire membership, and then we'll move forward from it. And that helps me and motivates me to make more videos week after week. So with that being said, I'll finish this lecture. It's a long lecture, so no time will be wasted. Any comments should be mentioned in the comment section. Till then, adios and bye bye.